Hello everyone, welcome to the introduction to bladder cancer and primary treatment options. My name is Saran Tesfai and I'm the Program Assistant for the Bladder Cancer Supportive Care Program. Today I'm joined by Dr. Marie-Pierre St. Laurent, a urologist, Dr. Ryan Urban, a radiation oncologist, and Dr. Haley Roberts, a medical oncologist. The BCSU program was implemented in February 2025 and is funded by philanthropic donations. We are very grateful for the support provided by the Prostate Cancer Supportive Care Program and Bladder Cancer Canada. This presentation will cover the following. First, anatomy of the bladder and pelvis, and an overview of bladder cancer. Then we'll go over the treatment options that are available in British Columbia for bladder cancer patients. And lastly, I will provide information to other modules that are offered in the BCSU program. Please note, we will be discussing several treatment options. However, keep in mind that not all these treatment options may be relevant or recommended for your specific situation. It is important to remember the options your doctor has discussed with you. At this time, I will hand over the presentation to Dr. St. Laurent.
Well, hello everyone. So my name is Marie-Pierre St. Laurent. I'm a uro-oncologist here in Vancouver, and I'll be discussing, as Sharon mentioned, bladder cancer, and then also we'll talk about the bladder removal, which is a radical cystectomy. So some of those surgical treatment. So starting about bladder cancer, first things to know is some basics information about the bladder anatomy. So here we have an image of a bladder in a male anatomy. As you can see, the bladder is a balloon-shaped organ that is located deep in the pelvis. It's located in front of the rectum. Prostate sits just underneath, and then there's a pubic bone just in front of the bladder. The urethra, which is a tube from where we pee, it is connected to the bladder, as you can see with the prostate. In female anatomy, once again, we have our balloon-shaped organ located deep into the pelvis. The uterus, it lies on top of the bladder. There is the vagina that is in close proximity of the bladder. We have the pubic bone, again, that is in front. And then there's the urethra, which is shorter in female, approximately 4 centimeters, and is directly connected to the bladder. Few facts about bladder cancer. It is the 5th most common cancer in Canada, so it is something quite frequent to find in our population. It is more frequent in male than in female, so it's about 3 male for 1 female. That's what the distribution we see in the population. About a quarter of the new bladder cancer that are found and diagnosed at a local stage are a diagnostic of a muscle-invasive bladder cancer. So about a quarter of the new cancers are muscle-invasive. And we'll talk about those in just a few minutes because they are treated a bit differently. There is some risk factor to develop bladder cancer, and really the number 1 risk factor is smoking. So tobacco causes bladder cancer. There's other exposition to toxins that can increase the risk of getting a bladder cancer, like work environments of dye, rubbers, or leather industry. And there's other risk factors such as pelvic radiation. Age is a risk factor. Increased age increases the risk of cancer. And then chronic inflammation, such as having multiple urinary tract infections or UTI, bladder stones, and then long-term catheter use. Now we're going to be talking a bit about the stage of the bladder cancer. So what are the different diagnoses and stage of bladder cancer? We split them for those localized ones into the non-muscle invasive, which is what you have on the left of the picture, and then the muscle invasive, which is on the right. They are different and they're treated differently. The non-muscle invasive bladder cancer, or NMIBC, those are the superficial tumors. Which only goes into the first layer, either the superficial or the first layer of the bladder. Overall, those tumors, they're treated with the bladder scraping, but we will follow up patients because they tend to recur, they tend to come back. And we see that approximately 40 to 60% of the time, people in their life who had the first tumor will have a recurrence. Overall, the risk that your non-muscle invasive progress to the muscle invasive, it is between 3 to 15%. Now the muscle invasive. Well, as the name says it has invaded the layer of the muscle, and it can keep growing and making deeper roots beyond the bladder, so into the fat or the other organ after it. It is unfortunately a more aggressive cancer, and because it's more aggressive, what we mean is that it grows deeper and it can spread. So there's a risk of metastasis, and with it, a risk of mortality. Because of that, we do require more aggressive treatment if we want to prevent the metastasis and the risk of mortality from the cancer. So here's another picture to show you a bit more, once again, the different stage, which will influence which type of treatment we recommend to do about it. So as you can see here on top, those are your superficial tumors. And then we have the muscle invasive, which is a T2. After that, we have a T3, which invades the fat layer around the bladder, and then the T4, which is what it invades the other organs around the bladder, which we've talked about, which can be the vagina, the uterus, the prostate for the males, or the pelvic wall. How is bladder cancer investigated? So maybe at this point you have had some of those done. So it initially starts with a cystectomy, which is a camera in the bladder that looks for the tumor. So visually, the urologist, we can see the tumor. We do need a confirmation of the diagnosis of the bladder tumor by doing a bladder scraping or a surgery that's called transurethral resection of bladder tumor, which is TRBT in short. So with this surgery, what we do, we perform the scraping. So we resect the tumor and we send it to the pathologist to look under the microscope and give us more information on that tumor. First, it will confirm if it is a bladder cancer. It will look at what type of cancer it is. Is it a low grade or a high grade? And what level of invasion of the tissue. It will tell us if it's a superficial, if it invades the first layer or the second layer, which is the T2 or the muscle invasive. Part of the staging, we will perform a CT scan, which is a scan to look in the chest, in the abdomen, and the pelvis to assess if there's evidence of cancer spread already, like in the lymph nodes or the organ. How do we treat? So non-muscle invasive bladder cancer, that means there's no yet invasion into the muscle layer. Usually how we treat this is with this surgery of the TURBT, where we resect the bladder tumor with a camera inside the bladder. So the TURBT is usually the surgery that we need to perform, and as itself should be sufficient for most of the tumor that are not muscle invasive. There is, however, other type of treatment which may be recommended in order to prevent the tumor come back, so to prevent the recurrence. First, you may be offered to receive a single dose of chemo inside of your bladder that will reduce the risk of the tumor to come back, which has shown to reduce that risk by 30 to 40%. So this is something is done right after the surgery when you're asleep, the catheter is inserted, and then the chemo is given inside of the bladder. In certain situations, the urologist will recommend that we do more treatment inside of the bladder to prevent the tumor from coming back and from growing deeper, so to prevent its progression to a muscle invasive. Those type of treatment, they are called BCG, or there's also some chemo that can be given inside the bladder. So those are treatment where we insert a catheter, we put the product inside of your bladder, and it stays there for an hour or so. There are some reasons and this specific criteria in which we will see some type of tumors should be treated with those BCG or treatment. And here there's a list of those. So for example, presence of high-grade tumor, if there's an invasion of the lamina propria, which is a T1, if there's presence of carcinoma in situ, which is called CIS, if the tumor is multiple, if they're large, if they come back frequently, and so on. So those are different things your urologist will be looking at and will recommend you to go through maybe BCG or intravesical chemo. So that's how NMIBC, or non-muscle invasive, is usually treated. There is, however, certain situation in which we will call the bladder tumor as being high risk or very high risk. And in those cases, we would discuss or recommend doing radical cystectomy, which is the bladder removal, or in certain situations, in more selected case, maybe a combination of chemo and radiation of the bladder. In short, why will we recommend to do the bladder removal for this superficial tumor? Well, it's because the very high risk, or that high risk, is the concern that it will keep growing deeper and spread shortly or soon in the next layer of the bladder, and we're concerned that it could spread. So that's the risk of progression. Those risk features that we are looking for, they're example here listed. Presence of high-grade tumor that recurs after the treatment of the BCG. If we see a T1 tumor that has some other kind of particularity that is given by the biopsy report, presence of LVI, presence of CIS, a really large T1, for example, and so on. There is also sometimes a bladder MRI that can be done, and the MRI can take us better picture and can tell us if there's already a suspicion that it invades through the muscle, so being a muscle invasive. So those are discussed by your urologist, and they may say, if you want to have the best outcomes, the chances that cancer never comes back, you should go for radical cystectomy because of those risk factors. So that's a discussion to have, and that's the reason why some people have non-muscle invasive bladder cancer but should be treated with a radical cystectomy up front. And now the muscle invasive. So as I said, about a quarter of the new diagnosis will be muscle invasive. What this means is that there's already evidence that the cancer invades into the muscle. It may invade beyond that, but at least we know it has gone to the point of the muscle layer. Today, the best recommended treatment approach is to have what is listed here, which is either the bladder removal or a combination of chemoradiation, and ideally receiving the neoadjuvant therapy before. And why do we treat this more aggressively, as I mentioned? Well, it is because of the risk that it will keep progressing. Unfortunately, we know that this muscle-invasive bladder cancer, if we do not treat it, about 50% of people by a year will be metastatic, and there's no cure at this point. So we want to prevent that from happening. So the standard of care, as I mentioned, is the bladder removal, which is called a radical cystectomy. In selected case, some people may be eligible or may be interested to have a bladder preservation approach, which is called trimodal therapy, and we'll discuss that later. And as mentioned here, ideally, if we can receive the chemo before the surgery, or what we call neoadjuvant therapy, it is improve the outcome. So we'll talk about that. So here's the next step of the presentation, and I will start by talking about the radical cystectomy. The surgical treatment of that bladder cancer, here we're talking about the bladder removal. What it means is that we remove the bladder. We will remove most of the time the lymph nodes around the bladder to see if there's already a spread in the lymph nodes. And there's other organs that we need to remove in the same times. And that goes back in terms of the first picture, which we showed the anatomy of the bladder. So in men, we will be removing the prostate and the seminal vesicle in the same time of the bladder because of its proximity, because the cancer can invade the prostate. In women, we will not remove the prostate, there isn't a prostate, but in women, unfortunately, we do often need to remove part of the vagina, the interior wall of the vagina, because they're really closely in proximity with the bladder, and it can often be invaded, so the cancer extends already into the vagina. Fallopian tubes are often removed. Obviously, someone who's not into a ability of childbearing. So in those people, removing the fallopian tubes, it can reduce the risk of ovarian cancer. So if childbearing is beyond us, then we will remove the fallopian tubes as a preventive measure. Ovaries and uterus, they sometimes need to be removed, not always. It really depends on the extent of the cancer. If it already grows into the uterus, then we'll remove it to remove all of the cancer. Once the bladder and the cancer is removed, then we need to fashion some kind of reconstructions for the urine to go somewhere. So here's a list of the 3 types of reconstruction we can do, and I'll go in details about those. So there's the ileal conduit, the neobladder, and then the continent cutaneous diversion or angina pouch. Before talking about the urine diversion, let's talk about why are some of the reasons to choose to have the bladder removal. In addition of being the great treatment, to remove the cancer and hopefully prevent that it comes back. So that is a given. But why are other reasons that we may want to have the surgery? Well, by removing the bladder, it can also provide other long-term benefit. For example, there are some people that have blood in the urine that keeps coming back because the cancer is there and that it keeps bleeding or causing pain or discomfort. So by having the surgery done, those bothersome symptoms of discomfort will be removed. So that is another benefit. There's other potential issues with the bladder. Some people have been experiencing, urine leakage or frequent urination and other type of trouble. And by removing the bladder, well, those trouble will be gone. So there'll be no need of waking up at night to go pee or having leakage of urine. This will be resolved. Some people have a bladder cancer that is blocking the kidney because of the ureters that bring the urine going in the bladder. They're blocked by the cancer, and they need to have a nephrostomy tube inserted in their kidney, which is like a drain that allows the urine to be draining from there. So by removing the bladder, we will be able to remove that blockage of the kidney and prevent the kidney failure and remove the nephrostomy tube. So that do provide some palliative, relief of those issues. The whole bladder will be looked under the microscope as well as the lymph nodes. It will provide us a definitive staging. We'll know exactly what the extent of the cancer inside of the organ. So the pathologist will tell us that final diagnosis. Finally, there's one thing to consider is that pretty much all of the type of bladder cancer can be treated with the radical cystectomy. I didn't go in terms of details, but there's different type of and subtype of bladder cancer, and some may be not necessarily suitable for radiation. Well, surgery, it is adequate for pretty much all of the bladder cancer that are not metastatic. Now, what to expect after surgery. So the radical cystectomy can be done, most of the place in Canada is done open. You can have robotic surgery some places. But in short, the recovery is relatively similar. About a week in the hospital, sometimes shorter, sometimes a little bit longer if there's any trouble. But in short, we will expect about 6 to 7 days in the hospital. When you're going to wake up, you're going to have the dressing on the incision where the scar will be, so the wound, there will be dressing there. There will be the appliance if you have an ileal conduit. You will have the stoma bag that will be there, you might have a drain. If you go for a neobladder, you might have a catheter one or two actually. One catheter draining the urethra. Some people will have an addition also probably a catheter, and you might have an abdominal drain. So those are things that will be on your abdomen, and most of them will will have less things when you're gonna go home. Right after the surgery, the pain will be managed either by the epidural catheter that the anesthetist will have inserted in your back, or pain management with injections of painkillers, or sometimes will evolve to take pills for painkiller. After the surgery, in the next few days, some people will experience nausea, like having a feeling of vomiting or just being a bit sick. So we do have medication to prevent that from happening. So that's something that you want to discuss with your nurse to ensure that we treat that. But it is possible to experience that. There is pretty much all of the hospital recommendation to do what we call an ERAS, which stands for Enhanced Recovery After Surgery. So what it means is that we will promote and want you to have an early and progressive return to the activity and eating. Meaning that the first day of the surgery, we want to sit you up and try to stand up. And then the next day, we'll start to stand up again, walk a little bit, and progressively do more and more. Same thing with the diet. That has been shown to improve the recovery and go faster and better. About that short week, like we said, in the hospital, and then you go home, and then you will have approximately 2 or 3 months of work. It depends what type of job you do. If you have an office work, you might be comfortable going back 2 or 3 weeks after the surgery. If you have a more physical work, obviously it will need longer. For people who no longer work, who are a bit older, we will see often that it can take 2 or 3 months before we feel like we're completely back on our feet and back to our normal. Obviously, this recovery will depend on the age that we have. There is some complication and risk related to the surgery, and here's kind of the list, the disclaimer of things that could go wrong or could be experiencing. The things to understand is that this is not exhaustive, but importantly, it is not going to happen in everyone, okay? So here's the things that we have to, that could be potential. One thing to understand is that a major complication are relatively infrequent. We're talking about maybe 15%. By major complication, what it means is something that's more major, meaning it might require another surgery, or it might requires that we do a procedure under local anesthesia, like intervention radiology, or that we may have to go for a day or two or something like that into intensive care unit to be monitored. So that's about 15%. It's not frequent, but it is possible. There is, however, frequent small complications, let's say. So any type of smaller, minor complication, it does happen about 65% of the time, and that is up to 90 days after the surgery. Here, what we mean is some complication that might be managed with medication, like pills, antibiotic, or dressings, or changing the wound dressing and things like that. So something kind of minor that we can adjust and go through it. But it's something to be aware that it could happen, okay? So the risk here, as written here, the risk related of having a surgery and having a general anesthesia, it will vary from one person to another, and is often based on your own health. Meaning, do you already have lung problems or heart problems, or what age are you, and cognitive functions, okay? So those will vary from one person to another, and you can discuss that with your surgeon or internal medicine, or when you have your consultation before the surgery. The risk that includes here that listed. So as listed here, the first one we're talking about is sexual dysfunction. So sexual dysfunction will unfortunately happen quite often following this surgery. It will depends on the degree of each patient and each cancer. So roughly 50-70% of the people will experience an impact on the sexual function. For male, well, we're talking about erectile dysfunction. As I said, it depends on how it works before the surgery, but also what the extent of the cancer, because the nerves that goes for the erections, they are often close to the prostate and the bladder and can be impacted. For female, we can see different type of dysfunctions. We're talking about shortening of the vagina, which can make intercourse either more difficult, more painful, in some people not possible to have penetrative intercourse. There is possibilities of having a bit more dryness, pain or discomfort, or impact on the orgasm or just general sexual satisfaction. So that's something to discuss with your surgeon if you are concerned about those. You can also sign up for some of the service that we have in our program to discuss with our sexual health clinic. So this is for sexual dysfunction. The other potential risk is having some bleeding. So we will see some blood loss at the time of surgery. Not often, but it could require blood transfusion. There's a risk of delayed bowel recovery. What that means here, 15% as the number listed, means your bowel are kind of slow to recover and you feel more bloated or nauseated. You might need to have a tube to decompress the stomach. Or it just takes a bit more time before the bowel movement start over again. There's risk of infection. There's risk of having wound complications or just poor wound healing. The risk of blood clot or having a blood clot in the legs or going through the lungs is a low risk, less than 5%, still possible, but we do give you medication to prevent that from happening. Usually about a month after the surgery, you're going to take those medication. At the time of the surgery, there's always a risk of injuring the other organs around it, like the bowel, the rectum. Usually that's a rare risk, but your surgeon may explain different things for you if there's anything particular to your situation. Overall, this is a rare complication. And then finally, there's a risk of mortality at 90 days. So this risk do vary. We have to explain it to the patient, meaning by 90 days after this type of surgery, we will see between 1 and 5% of mortality happening. It does vary greatly based on the patient's health. We do this surgery often for people that are 80 years old plus, and this may not be the same as someone who's 60 years old. And age is not the only thing. There's different, heart function and so on. So that can be better discussed with your medical team before the surgery. Now we'll talk about the type of urine diversion, and just to be sure we're on the same page, here's the list of a couple of synonyms. We're talking about the same thing in the box, okay? So an ill wall conduit is an ill wall loop, it's a urostomy or the abdominal stoma. A neobladder can be called internal diversion, a Studer, or Ottman. Those are just surgical techniques, but they're pretty much the same. And there's continent cutaneous diversion, which is the catheterizable pouch. We often call it Indiana pouch. Ill wall conduit. So this is the surgery the type of urine diversion that is most commonly done and most commonly chosen by the patient, roughly 80-90%, but it can vary obviously from one place to another. So ill wall conduit, to do that, what we use is a small pieces of the intestine, about 15 to 20 centimeter that we use, and then we will create a stoma on the abdomen. And the urine will be carried through the stoma and will be dripping into the bag and will have to be emptied regularly. As shown in the picture here, so we have this piece of intestine that we take, and then we will bring the ureters, which are the tubes that bring the urine from the kidney, and we'll bring that into the conduit, and the other end will be brought to the skin to create the opening, which is called the stoma. The bag that we use, it's an appliance, is sticky with just some kind of glue to your abdomen around the stoma, and the bag will have to be changed every once or twice a week, approximately twice a week, and then you will regularly empty the urine from the bag into the toilet, as if instead to go pee, you're just going to empty the bag into the toilet. The neobladder, to do that internal diversion, we use a longer piece of intestine, about 50 to 60 centimeter, and we create a substitute bladder. It is made of bowel, it's not made of bladder. So the bowel that we use, we will open the bowel and we will fold them differently and we'll sew it back differently. And then one opening will be made to bring it and connect it to your urethra. So you'll be passing urine by the urethra, the same hole as you pee today. The ureters will be also brought to be joined, so the urine coming from the kidney. There will be some learning in terms of how to empty the neobladder, how to pee, because it will be different. You're not going to have the same sensation as a bladder because it's a substitute bladder made of bowel. There will be some learning of how to gain the control and how to push by, how to pee and how to use your abdomen muscle to contract and empty and relax the pelvic floor when it's time to void. Lastly, the continent cutaneous diversion, like I said, often called the Indiana pouch. It's important to know that it's not all of the surgeons who's familiar or to do that surgery, because it's not often asked, so it's not all of the surgeons who are experienced and do it often. About 1 or 2% only, kind of what we see of being patients choosing that type of diversion. So if you are interested, you can ask your surgeon if they do it, and if they want to refer you to someone else. So to do this one, we use again bowel. We use a longer piece, but we also use part of the colon. So about 40 to 60 centimeter of bowel is being used, and we create this internal pouch. The ureter, as you can see, are also brought to the new pouch, but we will make a smaller channel, and that is brought up to the skin to create a small stoma. Inside of this small stoma in this channel, it will make a mechanism to prevent the urine from leaking. So it will be a continent. So continent meaning not dripping, a continent diversion. But in order to empty it, you will have to drain it by inserting a catheter through that small opening by the small stoma and draining it. So the catheter will have to be inserted by the patient multiple times a day to drain the pouch. Let's say, as usual, you go pee maybe 6 times a day or a bit more. So you have to insert a catheter when it's time to drain it. There is no need to have an appliance on your abdomen, so there's no stoma bag. So it stays dry. We do recommend sometimes to put a little gauze, just like a little Band-Aid or something, to prevent that it gets rubbed under your clothes and that there's nothing happening there. But it will allow you that from the external, it does not really look like you had something happening there. There's a disclaimer for both continent diversion and neobladder. You may have discussed with your surgeon and decide to go with one type of diversion, but there is always the possibility that at the time of the surgery, we're unable to do that type of diversion. It could be because of your anatomy inside, how you're made, or it could be because of the cancer, a couple of things from the cancer that preclude us from doing the internal diversion or the internal pouch. So that means that we explain always that to the patient, that you may wake up and we may have been forced, or we had to do a ileal conduit where you wake up and having the stoma on your abdomen. So it's not often that it does happen, but it is always a possibility. How do we choose? That's often discussions with you and your surgeons, but there's different health factors that will influence us in our decision. So here's a list, a couple of things that will influence us or say that we should go more with the ileal conduit as the stoma as the best approach. So some reason that makes the neobladder or the pouch not suitable. Well, first, inflammatory bowel disease like Crohn's disease, renal failure, liver failure, people with major heart or lung issues, lung disease. If we have previously pelvic radiation, we cannot do a neobladder in those situations most of the time, unfortunately. Age is listed, but age is always a relative thing. There's people who are 80 years old who run marathons, and then there's different type of people. So age is really not, it's relative, but we do tend to see people of older age preferring a simpler procedure, which is the conduit. People who have poor bladder control, like pelvic floor not being good, well, it's not recommended to do a neobladder because you're going to have more incontinence. If you have trouble getting to the bathroom, standing up, or having being in a wheelchair, or not able to have a good dexterity, then you want to stay away from the neobladder or the continent pouch because you will have to use your hands, do catheter insertion and things like that. And if not being able to reach your genitals, because if you have a neobladder, you might have to insert a catheter, so you have to be able to reach there. For those reasons, it is easier and simpler, and the quality of life will probably be better if you have your stoma, a conduit. Now, what are the potential benefits of choosing an ileal conduit as opposed to the other type? So by choosing an ileal conduit, what you can expect is a shorter surgery, so it's a bit of a quicker recovery. The urine will be collected into the bag, around the stoma. So in general, it is simpler to take care, either by yourself or a caretaker. So the stoma is what is the easiest overall for long term in terms of management and care. Overall, there's also less risk of complication by the fact that it's slightly simpler. There is some things that you can avoid in terms of complication by choosing an ileal conduit. Meaning, if you go with a conduit, you avoid a complication, for example, of the neobladder. Meaning, a conduit, you do not have any urine leakage. You're not going to have to wear diapers or anything. There's no need to insert any catheter. There's no need to have pads or incontinence protective device or underwear. And there's no need of waking up at night to go pee, because this is behind you. You will have the bag that you can connect to a bigger urine bag, and you sleep through the night. So those are kind of advantages that you might want to go for a conduit as a simpler procedure to recover from, but to manage on a lifelong way. There's possible disadvantage of going with an ileal conduit. For example, there's possibilities of a specific complication that is called a hernia around the stoma. About 15% of the people will develop a bulge around the stoma, which is the protrusion of the bowel into that hernia. Sometimes it can be painful, it can be visually unappealing, and not always problematic, but some people may have trouble with the appliance, the bag not sticking. So for some people, we will require a surgery to fix that. Another complication that can happen is tightness around the stoma when it does not heal super nicely and it narrows down. So that's stenosis or tightness. It's not frequent, about 3-5%. It may need a repair to stretch to keep that open, and sometimes it may need a surgery to fix this problem. There is possible benefit of choosing a neobladder. So what reason to choose for a neobladder? Well, it is the things that will look the most as if we didn't take your bladder out. On the external appearance, you will look as if you just have a scar from a surgery, but you will look as if you don't have anything wrong into your bladder. You'll go to the toilet, you pass urine by the urethra as if we didn't really touch you, okay? So you're not gonna have a stoma, you're gonna go to the toilet most likely and void on your own naturally. there is possibility of avoiding some complications related to the stoma. So the hernia, well, we don't see parastoma hernia if you have a neobladder. The tightness of the opening around the stoma, that is not a problem if you have a neobladder. The skin irritation, the trouble with the appliance or putting it in and on, and getting those products, well, you're not going to need that if you go for a neobladder. There is, however, some possible disadvantages or specific to neobladder, and you have to understand and be aware of those possibilities are listed here. So by choosing a neobladder, what can we expect of the outcome? About 80 to 90% of the people will be dry during the daytime, meaning no leakage. However, 10 to 20% of people will have some degree of leakage of urine during daytime. In between peeing, they may drip, okay? And that can require, for example, buying pads or having, for men, we can sometimes see penile clamps or having to do some things to improve that. So that's about, the risk of leakage during daytime. There is, on the other end, the problem where we're unable to pee. So about 70 to 85% of the people will be able to pee and empty the neobladder. However, that means 15 to 30% chance that we're unable to empty the neobladder. And if we're unable to empty, that means we need to insert a catheter into the neobladder multiple times a day to drain it, okay? We tend to see a bit more of that problem of retention in the female. The men tend to have a bit more of incontinence, the leakage, okay? So this is what we can kind of expect, and that's something you have to be aware. Although it might not be that frequent, you have to be willing to accept you may need to insert a catheter. As I said, a bit more frequent in female than male. During night, we will see about half of the people that are dry, but meaning about half of the people will have some leakage at nighttime. A bit more frequent in male than female. So that experiencing that leakage at night, it is for different reasons. Some people may not have a pelvic control that is perfect, but often it's also that the bladder, because it's not a real bladder, it's made of bowel, you will not get the signal to your brain when the neobladder is full and it's time to wake up to go pee. So that might not happen. So there's ways to try to improve that, like putting an alarm clock to go preemptively empty your neobladder once in the night to prevent that it overflows and leak. But it is something to understand that it may happen. The possible disadvantage of a neobladder. So here's a list of specific things that can happen through the years. We can see urine tract infection a bit more frequently in the neobladder and the continent pouch than the bag. Stone can happen in the neobladder, so in the pouch that accumulates from the mucus. There's also some possibilities of, we call that metabolic disturbance, like meaning in your blood, the pH might not be steady, and it is easy to take care of by taking bicarbonate, like it's just some kind of powder we can do. But with time, it can make your bone a little bit thinner. So it is important to take calcium and vitamin D to prevent that. There is the possibilities of declining the kidney function overall over time, especially if we're not emptying the pouch regularly. So that's something to keep an eye on, to be aware. Also, we will see a lower level of vitamin B12, usually starting 3 to 5 years after we had those neobladder or intima pouch, because we use longer pieces of bowel. We need to simply do blood tests to check the level of the vitamin B12, and if it gets low, we give supplements. Usually, we give you those vitamins starting 3 to 5 years after surgery. And finally, we can see change in the bowel frequency, of the frequency of the bowel movement. So it can change one patient to another, but be aware that the pattern of your bowel movement may change over time. And we do see a bit more frequent bowel movement, and people have an intima pouch because of the bowel we use. The last one we have to talk about is the benefit of the intima pouch. So by choosing an intima pouch, why will we want to do that? Well, you don't have a stoma. You have a tiny, tiny stoma where it does not really look, and you do not need to have the appliance. the small stoma, the small opening will require that you insert a catheter, as shown in the picture here, to drain the pouch, okay? And you'll be passing the urine this way. The advantage of going with this one is that you're not going to have a leakage by the urethra, so there's no incontinence or needing to wear protective underwear or pads, because there will not be anything dripping there. By choosing the Indian pouch, we don't have the big stoma with the appliance, so we don't need to buy those things. We don't see skin irritation around the stoma and those sorts of things. So from an outside visual, what does it look? As shown here on the picture, it's visually barely recognizable, but we do need to, for a lifelong period, to insert a catheter in and out to drain the pouch. Some of the possible disadvantages specific to the Indian pouch, we can develop a bit of tightness at the opening, about 5 to 25%, which if that tightness happens, it might make it a bit more difficult over time to insert a catheter, and sometimes that needs to be revised, either dilated or sometimes a bit of a surgery to repair that. About 0 to 20%, so kind of number varies, but we can see stones developing into the pouch. So we can develop stones, and it's often because there was too much mucus and the pouch was not regularly flushed, irrigated enough. So those stones they may need surgery to be removed if they're quite enlarged. Lastly, leakage of urine is not that common, but it could happen if you have leakage around the stoma. Often a small amount, and it's more a sign that we need to empty the pouch more regularly, and sometimes we need to do a bit of a surgery to fix and repair. So let's conclude this part of the potential disadvantage of the different type of diversion. So this concludes my parts.
Hi everyone, thanks for joining this talk. My name is Dr. Ryan Urban. I'm one of the radiation oncologists at BC Cancer Vancouver, and today I'll be continuing the talk about muscle-invasive bladder cancer, focusing on trimodal therapy and specifically radiation. So what is trimodal therapy? Trimodal therapy, or TMT for short, for bladder cancer, is a treatment approach that basically combines 3 different things. The first is a maximal resection of the bladder tumor, also referred to as a TURBT. And then 2 other things, including chemotherapy and radiation therapy. And the goal of combining these 3 modalities of treatment is to treat the cancer effectively while allowing patients to keep their bladder. This option is usually reserved for patients with a good bladder function and who have a low burden of cancer. So what does good bladder function mean? Well, that means that there's an absence of symptoms such as significant urgency, frequency to pee, leakage of peeing, or difficulty emptying the bladder. Because we want to preserve bladders that are functioning relatively well, because if they're not functioning well, there may not be a point in actually trying to preserve the patient's bladder. And what does a low burden of cancer mean? Well, generally that means the tumors are smaller the better, but less than 5 to 7 centimeters. And they do not go beyond the muscle layer, and most can be resected via that TURBT. So with the camera, they go in and take out as much as the tumor as they can. And this is a diagram of how trimodal therapy works and the schedule of the treatment. So the first part, again, is the TURBT. That's where the camera goes into the bladder and a device is used to scrape out the bladder tumor as much as possible, and ideally all of it if they can. Some instances we do give treatment called neoadjuvant treatment prior to the definitive treatment, which in this case is the radiation therapy. Occasionally patients will get this neoadjuvant treatment mostly involving chemotherapy. That's not always the case. And if that's omitted, you go right on to the definitive part of the treatment, which involves radiation therapy in combination with chemotherapy. And usually that takes over place of about 4 to 6 weeks. Following all that treatment, you adhere to a regular follow-up schedule. So that includes cystoscopies, which is the camera into the bladder, and urine cytology, which is just peeing into a cup and looking under the microscope to see if there are any suspicious cells. And we do that every 3 to 4 months for the first couple of years. and then every 6 months for the next couple of years, and then once a year, basically for life. We also do CT scans approximately every 6 months for 2 years and then once a year. And what these tests do are to monitor for the cancer coming back either within the bladder or outside the bladder. Now, we do combine radiation therapy with chemotherapy at the same time when we deliver this treatment. Low-dose chemotherapy is added to radiation to make the cancer cells more sensitive to the radiation. So the chemotherapy that is used for bladder cancer acts as a radiosensitizer, making cells more vulnerable to the radiation damage. And this increases the effectiveness of the radiation treatment. And studies have shown that the use of chemotherapy with radiation results in better outcomes than if you just use radiation alone. So they improve the local control rate, so controlling the tumor within the bladder, and reduce the risk of the tumor coming back. Bladder radiation alone, without chemotherapy, is thought to be inferior to bladder removal by surgery. So really what we're trying to compare is radiation and chemotherapy together compared to surgery. But if you do not do the chemotherapy with the radiation, we do not think that the radiation is comparable to surgery. So when do we consider trimodal therapy? We've learned a lot about surgery in this talk, but when do we consider trimodal therapy? So studies are unclear whether the trimodal therapy involving the chemo and radiation compared to surgery are equivalent. But evidence would suggest that in carefully selected cases, the trimodal therapy is as successful as surgery in treating the cancer and allows patients to keep their bladder without surgically removing it. We know that in about 15 to 35% of cases, the cancer persists in the bladder or comes back or recurs after this trimodal therapy, and a salvage cystectomy is needed. In those cases, a neobladder is usually not possible or recommended. So a lot of times our patients will ask, well, is trimodality therapy allowing me to keep my bladder equivalent to the cystectomy or removing my bladder with surgery? It's a very complex question to answer. Unfortunately, studies comparing these two types of treatments are generally flawed because there's such different treatments, and there's an absence of big randomized trials that are high quality. But with the best evidence that we have, we think that in selected cases, trimodality therapy is equivalent to bladder removal for the bladder cancer survival and risk of metastases. We acknowledge, though, that this will include about 15% of patients that will eventually need cystectomy or removal of the bladder in the future for the cancer coming back. So who would be the ideal candidate for trimodality therapy? And this list kind of gives some guidance of what kind of criteria we are evaluating. But ideally, we want bladder tumors that are confined to the bladder, and ideally smaller the better, smaller than 5 to 7 centimeters, and not spread beyond the muscle layer. Ideally, most of the tumor is removed via the TURBT. There is no kidney blockage or what's called hydronephrosis. Patients have a good bladder function, so they're happy with their bladder function. They don't have symptoms so significant like peeing often or urgently or leaking that are really affecting their quality of life, because if that's the case, well, maybe it's not important to preserve the bladder with radiation and chemotherapy, and maybe it's better to remove the bladder with surgery to alleviate some of these symptoms. Patients have to have a commitment to treatment and a lifelong surveillance schedule. So after completing the radiation and chemotherapy, you have to monitor the bladder with the cameras and also the CT scans regularly to make sure that the tumor is not coming back and catching it early if it does. And you have to be healthy to undergo both radiation and chemotherapy. So you have to be your body has to be healthy enough, and you can't have other health problems that preclude the use of radiation and chemotherapy. And then there's some other considerations, particularly with radiation therapy. Some contraindications are patients that have a difficult time receiving radiotherapy are those with inflammatory bowel disease or types of collagen vascular diseases like lupus or scleroderma. And usually in those cases we would favor a surgical approach as opposed to radiation. So how does radiation therapy work? Basically, what radiation does is causes DNA breaks, which leads to cell death and prevents the cancer cell from growing and dividing into a larger tumor. Now, Cancer cells have abnormal DNA, so when the radiation causes this DNA damage, the cancer cells are not able to repair this damage. Whereas normal cells have normal DNA, so the damage caused by the radiation, the normal cells are able to repair themselves. And that's how radiation is delivered over 4 to 6 weeks, and we're able to slowly kill the tumor while allowing the normal tissues to heal and repair themselves over that time. We deliver radiation with an external beam radiation technique, and this picture in the slide depicts that. So a patient is on what we call a couch that moves, and a big machine rotates around 360 degrees. And that machine shoots high energy X-rays, and it's called a LINAC, or a linear accelerator, from 360 degrees and targets the areas that we want to treat. So how do we target the areas we want to treat? Usually we get a CT scan. That's a special type of CT scan only done at your cancer center. And we use that to outline your bladder and the tumor and design a treatment plan based on your anatomy to target those areas and avoid the adjacent areas that cause side effects, such as your bowels, your rectum, or your other tissues in the vicinity. And then once we've designed that treatment, you come each day for a period of 20 to 32 treatments, Monday to Friday, no weekends or holidays. And each treatment only takes a few minutes, but you're probably in and out the cancer center roughly 30 minutes a day. So what are some side effects of the radiation? We can divide those into early side effects or late side effects. Early side effects happen during the radiation and shortly thereafter. And then late side effects can manifest either months or years down the road. The early side effects kind of generally accumulate during the course of the radiation, whether that's 4 to 6 weeks, and they last for a couple weeks after before they start to improve. Some side effects that patients may get are fatigue. With any type of radiation, patients can get fatigue. You can get irritation of the bladder where we're treating, which causes short-term peeing often, so frequency, or urgently. That irritation can also happen to the bowels and rectum, causing you to have loose stools or diarrhea that can usually be managed with dietary changes such as reducing your fiber or over-the-counter anti-diarrhea medications. For men, erectile function drops within 6 months, and then a partial recovery about a year later, and then a subsequent age-related decline as men get older. The long-term side effects, again, can manifest years down the road. Patients may notice chronic changes to the bowel and bladder habits in terms of how often they're using the bathroom to pee, how urgently they have to pee, or how prone they are to getting things like diarrhea or gas, depending on what they eat. These changes to be so significant to alter sort of the day-to-day activities of patients is uncommon, but most patients would notice some element of change, but they're usually mild. There can be leakage or incontinence, but that is not common with radiation at all. Other side effects include bladder inflammation, which can cause bleeding. That is rare but possible. Similarly with the rectum, causing damage to blood vessels that become more weak is rare. About 1 to 2% of patients would need a cystectomy, so a removal of the bladder for chronic side effects of treatment that are impairing quality of life. So either recurrent bleeding from the bladder or just very poor bladder function that patients are not satisfied with. So overall, that risk is very low. And there's about a 1 in 200 risk of causing a second cancer from the radiation exposure in that area. What about bladder cancer recurrence after trimodal therapy? So we can divide the bladder cancer recurrence into 2 different categories. One category would be the bladder cancer comes back, but it's non-muscle invasive. And the other one would be recurrence or persistence of a muscle invasive tumor. So for non-muscle invasive bladder cancer recurrence, about a quarter of patients will develop new superficial bladder cancers after initially successful trimodality therapy. And this requires treatment, usually with the TURBT or the removal of the bladder tumor with the camera, with or without intravesical, so inside the bladder, BCG treatment, which is instilled within the bladder for a period of time. And side effects of these treatments are very similar to those patients that have non-muscle invasive bladder cancer without previous radiation. Now, if you have a muscle invasive bladder recurrence or persistence of the tumor after the trimodality therapy, this happens in about 15% of patients. and these usually require a cystectomy or removal of the bladder. This is usually done in experienced centers with experienced urologists, and the risks of surgery, as we've discussed in this talk, are comparable to patients without prior trimodality therapy, but surgery can be more difficult or take longer because of scarring of the radiation. And often it's not possible to do a neobladder after the pelvic radiation, so an ileal conduit is often performed. That's it for the radiation component, and I will pass it off to my colleague to talk about chemotherapy and other systemic therapies.
Hi, my name's Dr. Hayley Roberts. I'm a medical oncologist and medical oncology fellow at BC Cancer in Vancouver, and today I'm talking about the role of systemic or drug therapy in muscle-invasive bladder cancer. So first of all, I'll talk about neoadjuvant therapy. Neoadjuvant therapy is a treatment that's given as a first step to shrink a tumour before we give the main treatment, and that main treatment is usually surgery but can be trimodal therapy. The usual schedule for this therapy is 4 to 6 cycles given every 2 to 3 weeks as an outpatient with a total duration of 2 to 3 months. Previously, this treatment was chemotherapy alone, but recently we've been able to access immunotherapy in addition to the chemotherapy in this setting. There are also multiple clinical trials running with newer treatment options, so if you're interested in this, it's worthwhile asking your urologist or oncologist about the options. So why do we give neoadjuvant therapy? We know from studies that patients who are able to receive this therapy prior to cystectomy or radiation have better outcomes. So compared to patients who have surgery alone, they have an improved survival by 5 to 10%. And the treatment is able to treat micrometastatic disease, that is, small cells of bladder cancer that escape the bladder, go to distant sites, but are invisible on or too small to be seen with a scan. This treatment can also result in tumour shrinkage, which can make the surgical removal of the bladder easier. And about 30 to 40% of patients will achieve a complete response. By that I mean that when the bladder is taken out by surgery and looked at under the microscope, we can't see any cancer left in the bladder. And these patients who achieve this complete response have the best long-term outcomes in terms of cancer recurrence and overall survival. We know that receiving this therapy before the surgery is much better tolerated than receiving it after undergoing a big operation such as a cystectomy. In terms of who is able to have this neoadjuvant therapy, it's important to understand that not everyone should or can receive this therapy, and this is largely because of other health conditions that patients may have that can be worsened by the neoadjuvant therapy. Frequent reasons that we choose not to give the treatment include reduced kidney function and heart failure, and also neuropathy, which is nerve damage sometimes caused by diseases like diabetes that usually manifests as tingling or numbness in the fingers and feet, as well as hearing loss. And the reason we don't give it in these settings is because these conditions can all be worsened by having neoadjuvant chemotherapy. Sometimes we hesitate to give it in patients who are older as well, for fear that the side effects could manifest more significantly for those patients. And this is because chemotherapy certainly has benefits, as I've discussed in the last slide, but it can also have significant risks. As oncologists, we like to make sure that we are doing more good than harm for our patients, so it's worthwhile discussing any concerns you have with your medical oncologists. And this brings me to the potential side effects of neoadjuvant chemotherapy. I'll note here that the side effects of immunotherapy are different, and I'll discuss these a little bit later. So, cancer essentially is the uncontrolled growth of cells. Chemotherapy works by targeting rapidly dividing cells. However, this can also result in some of the side effects because it can result in reduced growth of normal cells. So this can result in reduced blood cell count. Particularly important and potentially dangerous is the reduced white cell count, which can increase the risk of infections. Reduced red blood cell count can also cause fatigue. Nausea and vomiting can be caused by chemotherapy, but I would note here that our medication, called antiemetic medication that we have to manage this nausea and vomiting, is much better than in the past. However, this can still significantly affect quality of life if it's not well managed. Patients can also experience loss of kidney function that can lead to stopping the treatment. And hearing loss or ringing in the ears, called tinnitus, can also occur. Nerve damage is not uncommon, and that often can present as numbness, tingling or pain, primarily in the hands and feet, and if it's severe, can eventually result in difficulties walking or using the hands. Mucositis can cause painful mouth sores and a sore throat, which can result in difficulty eating and swallowing. Now, most of these side effects will resolve fairly quickly after stopping the chemotherapy. However, some can continue long term, and in particular here I think about the hearing loss or ringing in the ears and the peripheral nerve damage, which often improve significantly after therapy but can persist for years or for a patient's lifetime. Now, this brings me to the next section of the talk, which is talking about adjuvant therapy. And adjuvant therapy is additional cancer treatment that's given after the primary treatment to reduce the risk of the cancer returning. And this is often given in certain cases where the cancer is more advanced. So this treatment can be chemotherapy. Now, as I've mentioned, we prefer to give this before the cystectomy surgery. However, if it was not received, or for a number of other reasons, we can give it afterwards, and that's usually given as 4 cycles or 12 weeks of treatment. As well, we can give immunotherapy. So immunotherapy I've already mentioned in the neoadjuvant treatment setting, but this works differently to chemotherapy in that it doesn't target those rapidly dividing cells, but instead it stimulates your immune system to destroy cancer cells. So it's also given intravenously through a drip, often every 2 weeks for up to 12 months after the surgery. Radiotherapy as well can also be considered in certain circumstances. Thank you for your time. We hope that this session has been helpful.
Besides this evening's session, what else will BCSC program soon offer? The Bladder Cancer Supportive Care Program is a new initiative consisting of 8 modules, each addressing a different aspect of bladder cancer care. In addition to today's presentation, the following modules are currently available: counseling, wound ostomy and continence care, managing the impact of bladder cancer treatments on sexual function and intimacy. And over the coming months, we will launch additional modules, including exercise for bladder cancer patients, nutrition advice for bladder cancer patients, pelvic floor physiotherapy for patients with a neobladder and bowel management needs, and lastly, metastatic disease management. Most modules will have both a group education session as well as a clinic for individualized recommendations and advice. Attendance at these education sessions are mandatory prior to booking for individual clinical appointments. We have set it up this way so that all the general information can be covered in the education session, so that when you attend your one-on-one appointment, you can optimize your clinic appointment with specialized care. Partners are always invited to all sessions, and all modules are offered both in person and virtually. If you have any questions, please don't hesitate to contact me. My information is on the final slide of this presentation, and I would be happy to assist you or ensure you are registered for the next available session. As mentioned earlier, the counseling module is now available. Each patient can access 6 private one-on-one sessions with our clinic counselor. These sessions provide a safe and supportive space to process emotions, whether you are newly diagnosed or navigating life after treatment. Appointments can be attended in person or virtually. If you are feeling overwhelmed, anxious about your bladder cancer diagnosis, or simply want someone to talk to who understands your journey, we encourage you to use this service. Emotional well-being is just as important as physical health, and we are here to support you every step of the way. The wound, ostomy, and continence care module offers a 1.5 virtual group education session specifically for patients who have been diagnosed with bladder cancer and are preparing for bladder removal surgery, also known as a cystectomy. This session is designed to help you feel more prepared, informed, and supported. It's led by a nurse specialized in wound, ostomy, and continence who will walk you through everything you need to know, including the pre-op and post-op care for each type of urinary diversion, and what to expect in the longer term after surgery. We highly recommend attending. It is a great opportunity to ask questions, reduce uncertainty, and take a more active role in your care journey. We recognize that bladder cancer treatments can have a profound impact on sexual function and intimacy. The Managing the Impact of Bladder Cancer Treatments on Sexual Function and Intimacy module offers a 1.5 virtual education session specifically for male patients. This group session focuses on understanding the sexual side effects of treatment and provides practical strategies for adaptation and recovery. In addition to the group session, male patients can book one-on-one appointments with our sexual health clinician and sexual medicine physician, who specializes in helping patients adapt to changes in sexual health. For female patients, we offer referrals to a gynecologist with expertise in sexual medicine to ensure they receive personalized expert care. We encourage patients to take advantage of these resources. They are an important part of the recovery and wellness journey. Please feel free to discuss with your primary care doctor, urologist, or radiation and medical oncologist on any of the information that you have received today from our presentation. There are also some exciting clinical trials that you can speak to your physicians or doctors about. For more information on bladder cancer, please visit the Vancouver Prostate Center or BC Cancer website. If you are interested in joining a support group for peer-to-peer support, please call or visit the Bladder Cancer Canada website. If you are interested in booking any education sessions or appointments, please reach out to me. My contact information is on the slide. Thank you so much for watching.